Gastric carcinoma. Etiology, pathophysiology, and pathology. Gastric carcinomas are adenocarcinomas and can be classified histologically as diffuse or intestinal. They are associated with atrophic gastritis and intestinal metaplasia, but there is no evidence that long-term drug-induced achlorhydria is associated with gastric cancer. Distal gastrectomy is associated with a 12-fold increased risk of gastric cancer after 15-20 years. There is also increasing evidence of an association between Helicobacter pylori and gastric cancer, with prospective serological studies showing a 3 to 6-fold increased risk, mainly of distal tumors. Countries with high rates of gastric cancer also have a high incidence of H. pylori infection. Epidemiology. The highest incidence is in Japan and China. In the USA, incidence is 10 per 100,000. Overall, the incidence is falling, but adenocarcinoma affecting the cardia and gastroesophageal junction is becoming more common. It rarely occurs before the age of 40 years, peaking in the 70s. Clinical presentation. Common. Small superficial tumors are often asymptomatic. Later symptoms are weight loss, 61%, abdominal pain, 51%, nausea, 34%, and dysphagia, 26%. Malaise due to iron deficiency anemia. Acute upper gastrointestinal hemorrhage. Rare. Vomiting from pyloric obstruction. Physical signs. Common. Usually there are no abnormal clinical findings. Uncommon. Epigastric mass. Malignant ascites due to peritoneal seeding. Rare. Enlarged supraclavicular lymph node, Thyrcose. NB. The red flag symptoms for urgent referral for suspected gastric cancer all suggest advanced disease. There are no symptoms of early gastric cancer. Investigations. FBC, an iron deficiency anemia is present in 42%. Tumor markers, carcinoembryonic antigen is not helpful diagnostically. It is elevated in 10–20% of patients with resectable tumor. Endoscopy, essential for histological diagnosis and assessment of size and position of the tumor, Fig 31. Abdominal CT, used for staging to assess whether a tumor is surgically resectable. Staging is graded from 1 to 4, dependent on the TNM, tumor, nodes, metastases, classification. Endoscopic ultrasound, useful in the staging of gastric neoplasia as it gives information on depth of invasion locally as well as lymph node involvement and may identify tumors that can be removed endoscopically by endomucosal resection. Treatment. Surgery. Indicated if early tumor confined to stomach, i.e. stage I. Chemotherapy. Neoadjuvant chemotherapy may reduce tumor bulk and invasion prior to surgery. Combined surgery and chemotherapy are better than chemotherapy alone. Conservative. Indicated for linitis plasticus, involving whole of stomach, or those with locally invasive and widespread metastatic disease. Complications. Hemorrhage. Prognosis. The 5-year overall survival rates are poor in the UK at 15%. Stage 1, confined to stomach, with surgery has a 5-year survival rate of 50% in the UK and 90% in Japan. Prevention. Screening by endoscopy is advocated in Japan, where 40–60% of early gastric cancers can be identified, but this is not the case in the UK, Europe, and the USA. Disease associations. Pernicious anemia is associated with a 2 to 3-fold increased risk of carcinoma of stomach.